I'm on the camp that doesn't think that there's sort of a set pattern, because just when you sort of identified the one kind of person that's going to be suicidal, you find thousands of others who are like that aren't. And so there are these individual differences that I think are fascinating, and that really our field and the work that you do, the work that I do, is really very much focused on, which is, why do people suffer in such a way that they think of suicide versus a whole variety of other ways that they might act out, or they might try to problem solve or deal with those feelings that have nothing to do with suicide. So I guess I'm in the individual differences camp, and mindful that just when you think you have somebody sort of squared away as being a high-risk suicidal person, they're mostly not going to kill themselves. And so we're still, I think, from my bias, looking at the phenomenology of suicidal states. And that's where I really like the work of Ed Schneidman and some of our founding fathers in the field, who really have looked at some of the commonalities around psychological pain, around poor problem solving, even evolving sense of hopelessness or irreversibility. But again, it's a very idiosyncratic thing, and there's sort of not one size way of understanding all suicidal people. In my mind, it's really a confluence of a whole series of circumstances and issues and concerns and day-to-day realities. We do research that looks a lot at psychological pain, different and separate from depression. So a lot of depressed people don't want to kill themselves. Some depressed people have a kind of pain that can only be ended by suicide. And so people with a lot of psychological pain, who then have a lot of stressors that bear down on their well-being. For kids, it could be getting bad grades or being ostracized by their peers or their parents breaking up. So a whole number of stressors, loss of sleep, that impinge on well-being is a factor. And then another factor is these sort of agitated states that people get themselves into. And if we're looking at it from a developmental perspective, it seems to me there's a lot of work, Thomas Joyner's work, some of the work that we do, that looks at suicide as an interpersonal phenomenon. And so, for example, Joyner talks about suicidal people having the perception that they're a burden on loved ones, or that they aren't able to affiliate or connect with people that they mean to be connected to. So there definitely is this interpersonal component. So taken together, all those elements, you're looking at dozens of different ways that people can get to the suicidal moment or conclusion. And then typically in that moment, there's a profound sense of sort of franticness or extreme upset, a sense that I can't bear this another moment. I've got to do something. Ed Schneidman is well known for saying it's a bad idea to kill yourself when you're suicidal. And what he means by that is you're not thinking well, you're not sort of problem solving well, you're not thinking about the range of options, short of something that's become very constricted and very sort of, I've got to do something, this is the only thing I can do. So I guess I'm saying there are a number of forces that come together, and that each individual suicidal person's moment, sort of when they literally or figuratively are going off the ledge, is defined by a number of things coming together to create a very intense, oftentimes frantic, oftentimes fueled by intoxication or alcohol or drugs, which we see a lot in completed suicides, to get the nerve or the courage to kill yourself. You have to override the natural evolutionary wired legacy or inheritance that we're not supposed to kill ourselves. So to do it is a very difficult thing. And a lot of things have to come together to override that sort of self-preservation kind of instinct. A real favorite question of mine as an assessment question is to ask people, when you're thinking about suicide, does it comfort you or does it disturb you? And you really do see a range of responses. There was a teenager I interviewed last fall, 17-year-old, who would have suicide pop in his mind while he was taking a shower in the evenings after football practice. And I said to him, well, when you have that thought in your mind, do you find it comforting to you? And he looked at me like I had three heads. He's like, no, I think it's effed up. It really freaks me out. It does not comfort me. Well, that's interesting, because there are many patients, especially with more of a chronicity or personality-based kind of problem, who will just almost be poetic. I mean, if you look at the poetry of Anne Sexton or Sylvia Plath, those are two ladies who can talk and write beautifully about suicide and about the comfort and the imagery that they were able to draw from their own struggles and experiences. And they were two people that took their lives, of course. And so that's a very different thing, isn't it? And so most clinicians aren't really trained to do this differential assessment. You know, there's just still this sort of ubiquitous homogenization of thinking about suicide as sort of this unitary thing, when of course, if they think about it, there's very different ways that people are suicidal. And I think we're getting better and better at sort of pinning down what some of those typologies or that lexicon or the taxonomy might be, which then opens the door to prescriptive treatments. I mean, that may be a really naive notion, but the idea of identifying different kinds of suicidal states that would then be matched with different kinds of treatments that are appropriate to that state.